Nagesh or
Yes,
Shivam
I am
sharing?
recording. I'm recording, Bharat.
Sure.
Please do let me know if you guys are able to see my screen.
Yes, yes, we can able to see.
Okay, so let me walk through the presentation of Aaseya Healthcare pre-authorization solution.
Yes, go ahead, Manohar.
Actually, my system is a little bit slow, so I'm unable to. Let me go ahead and reshare my screen again. So here is the overview of Aaseya Healthcare Pre-Authorization Solution. So on a high level, what we have done is we have created a use case for a prior authorization request. Now, what is prior authorization? To get insurance coverage for certain medications, tests, and other medical care, your health insurance provider must approve, that is, authorize the care prior you receive it. This is the understanding of prior authorization. Now, without prior authorization, you may end up paying the entire cost or be denied the care. Now, let me give you an example of what is prior authorization. Suppose if we go ahead and visit a dermatologist writes a prescription. Now, your insurance provider tells you and your dermatologist office that the prescription requires prior authorization. Your dermatologist office creates a request for prior authorization and submits it to the insurer provider. Now, your insurer provider decides whether to approve it or deny it. If your insurance provider denies a request for the prior authorization, your dermatologist can appeal the decision. This is the understanding of prior authorization. Uh, This is the Pega patent situational layer cake architecture for prior authorization, which organizes process rules, data models, and UI into layers, making complex application structures easier to manage. As you can see on the Pega platform, we have Pega Care Management, and on top of Pega Care Management, we have the application, which is prior authorization request. On the high level, we have this is the case life cycle of prior authorization where we have intake, auto authorizations, clinical review, MD review, notification.
Manohar, this is Bharat here.
Yes,
Um,
Bharat.
if you go back to the first slide, I have some feedback there.
Yeah.
By the way, I'm so happy to see you talking this language, right? It means that you have understood this domain really well, Manohar. So thank you so much.
Yeah, thank you,
Uh,
Bharat. Yeah.
so essentially,
Bharat,
there
not
are three.
sorry, Bharat. Not only Manohar, this entire team is now, care management framework enabled, I would say.
Yeah, and it's so interesting, Abhishek. I mean, this particular domain, right, is so interesting. Even my journey started only, couple of years ago, and I was like, okay, this must be very one of the boring, area where everyone is so standardized, right? I mean, healthcare as a practice is running for ages, but there is
Yeah,
so much innovation we can do, right? So much digitization that can happen. So I'm really excited about, this particular industry.
sure.
Uh, So Manohar, I mean, there are essentially three players, right? I mean, there is a payer, then there is a provider, and there is a member, right? So it's a triple constraint of these three parties in which we need to operate. So on your the next slide, right, where you were explaining about a pre-authorization, if we could bring those three persona, member is like someone like you and me who is seeking medical treatment. Payer is who will be paying, right? For this treatment, whether it's the insurance party, government, or whoever else can be termed as payer. And then there is a provider who is actually providing the treatment. So we should bring
Right.
in that those three personas. And this diagram is good, but I think we'll have to create our own diagram, right? Articulating, I mean, similar journey.
Sure.
Oh,
But
okay. Okay, bro.
Good. Uh,
yeah. So
Karthik,
on
let
a
us take the notes, Karthik.
Yeah, I'm taking.
So on the high level, the case life cycle of prior authorization is intake, auto authorization, clinical review, MD review, and notification. Okay. Uh, so in in intake, what happens is we will initiate a prior authorization request. In auto authorization, we will check if there are any prior authorization cases got created. If not created, then based on the depending rules configured on the prior authorization request, get automatically approved and other get reviewed. Now, in clinical review, we attach the clinical guidelines and request is further processed for MD review. In MD review, the request can be approved or rejected. In the notification, and notification can be opted out for the member, and an admission case gets created. This is the high level architecture of prior authorization. Now let me walk you through the user journey one by one. This was the overview. Now let me take you guys into detail of the user journey of intake. Now, the application supports prospective and retrospective review of authorization requests in the following areas. One is inpatient, that is admission review. Two is outpatient, that is health services review. Three is referral requests, which is specialty care review. Four is prescription request, which is drug review. Now, this is the business flow for inpatient service requests. Okay, so we have a drop down wherein we can select the authentication type. Now, if we go ahead and select authentication type, what will happen is the journey. Okay, before that, I want you to let you know that inpatient care is a care provided in a hospital or other type of inpatient facility where admission is required. Now, when we select the authentication type as inpatient, we will enter the initial information either through email, phone, or letter. Now, once we enter the initial information, we get the policy plan details. We will select the requesting provider along with the service provider. We will select the facility, and in enter details of request, we will enter the place of service, admission date, and requested length of stay. Now, let me go ahead and tell you that based on the authentication type, visibility conditions are configured on the same screen. Now, for inpatient, we will have the requested length of stay visible, but whereas for the authentication type of outpatient service, we do not have those details. The flow is very similar. Now, but as I've said earlier, based on the visibility, the details may vary. Now, in the outpatient service, what is outpatient service? It is outpatient care refers to any healthcare consultation, procedure, treatment, or other service that is administered without an overnight stay. So when an overnight stay is not required, we do not have to enter the length of days that needs to be admitted for inpatient. So we don't have those details. As I've said again earlier, based on the visibility, the details get popped up. So we will again select the service provider, select the facility, review the outpatient service information is entered, and we will review the outpatient service request. This is the outpatient authentication type. Now, let me go ahead and walk you through the referral authentication type. What is referral? A request from a healthcare provider to a health plan to obtain authorization for referring an individual to another healthcare provider. Now, specialty care review information. Based on the visibility here, the type of information that is displayed is either an appointment date and number of requests visits requested. Information is displayed in enter state specialty care review information. Now, once this information is entered, we will select the diagnosis, review the specialty care, and we will go ahead with review a specialty care request decision. What is specialty care request decision? It is nothing but it is configured to approve specialty care authorization referrals if the patient is eligible. The system resolves the request as approved and displays a on the notification screen. This is about referral. Let me go ahead and walk you through the prescription, drug prescription. Now, in drug prescription, a prior authorization requires the prescriber to receive pre-approval for prescribing a particular drug in order for that medication to qualify for coverage under the terms of pharmacy benefit plan. Here we will enter the case details, select the patient, we will select the requesting provider along with the service provider, we will select the facility. Along after once we select the facility, we will go ahead and enter the information for the prescription date, prescription number, place of service, what is the service type. Once the drug code is selected, we will review the details and we'll proceed further. This is about the drug review authentication type. Now, similarly, there is an alternate user interface for prior authorization. What if the member details are not displayed on the system? So you cannot proceed with any of the request or the authentication type. So we have a screen wherein we do not have the member details. So the screen looks like a single screen flow wherein if a record member is not available, we can create a member, and once the member is created, you can uh, a temporary record gets generated in the system. Now we can use the temporary record and we can select the service provider and select the facility and cater the services to the member. Now let's go through the user journey of auto authorization. Before that, I want to ask you, are there any questions?
So Manoj, not question, but
Yeah.
in terms of our story deck, right?
Yeah.
See, we should have 3-4 slides to cover first of all the industry context, right? I mean, what are the challenges and what issues we are trying to solve using this solution. Then we should have a slide around our customer journey, the journey of pre-authorization, which all personas are involved there, right? And what are their pain areas, and again how our solution can address those. Then then we should have a solution diagram, a typical solution diagram we use on any Pega project, right? That diagram shall suffice. And then we can jump into demo. So we actually don't need more than 3-4 slides to set the stage.
Okay. Okay.
Does
Bro.
that make sense?
Yeah.
All right. Okay. Sure. Let me go ahead and walk you through auto authorization. So
Then we can directly jump into the application walkthrough, or shall we continue, Bharat? Yeah?
No, so see, there are more slides, we can go through them, but my request would be to condense it into 3-4 slides, right? Because if we get 1 hour for a demo, then 15 minutes for setting the stage through deck, and then 45 minutes for actual demo. That's how we should be split. If we get 30 minutes, then accordingly, I mean, we have to reduce time for slides.
Okay.
Go ahead, Manohar.
yeah, okay. When prior authorizations are created and submitted for processing, depending upon business rules, some requests might be automatically approved. Now, business rules are configured to validate provider specialty, service type, submitted procedure, and diagnosis codes. Okay. So based on certain business decision rules, some decisions get automatically approved or resolved when prior authorization is not required as per business rules. For example, an outpatient request type with a service type as cardiac rehab does not require an approval. It gets automatically approved. let me go ahead and walk you through the user journey of clinical review. All requests are not automatically approved, are routed to the designated work basket pending clinical review. Now, based on access roles that are configured in the system, users who have access to the work basket service coordinators and service managers can process the requests. After the clinical review, staff has researched, attached the applicable clinical guidelines, and confirmed the availability of any supporting documentation. The request is ready for processing. Now, while processing a request, once we are done with clinical review, the request gets processed for the MD review. Here, MD review is nothing but medical director review. There is a once the clinical review is done, there is an option to check the route to MD flag, and once it is checked and we click on submit, that's when the prior authorization request gets routed to medical director review. If medical director review has determined that the service or admission stay is not certified, then the request is rejected. Now, the scenarios which are mentioned in the MD review, will see it in the live application. But let me tell you that once the MD review is once we are completed with the MD reviewer, then there will the prior authorization requests get routed to the clinical review, and then once the request is routed to the clinical review, there will be a notification. There will be an option to notify the member, and once we notify the member, and a case gets created. That is an admission case. So here is the walkthrough of the deck.
Uh,
Thanks, Manohar. Bharat, any questions? Like, you have already provided your suggestions.
No, I think we are good. And how do we make this deck look more richer, right? That's another angle we should look at.
Karthik, can we give it a try, Karthik?
No, Karthik won't be able to do because I have worked with Karthik, right? I mean, we'll need someone with that kind of I would say experience, but that creative hands-on, right?
That the marketing team can help us, right? Like, once we are done with the content, maybe, Bharat.
Ideally, yes, Abhishek, but they are super busy. There are so many projects going on. So we'll have to find, see, maybe this is a conversation we need to have with Somu, the BA team, right, lead. I would eventually want BA team to become, self-reliant in terms of creating, a compelling deck.
No, I would still say give one more chance to Karthik, because he has done considerable good work in preparing the AIMS deck. Okay, so
Okay.
okay, so let's Karthik, take it as a challenge. Karthik, like in the before the next demo, prepare a deck, similar or maybe better than what we did for AIMS. And if still we are struggling, maybe we will reach out to marketing team or anyone else for help.
okay.
Correct. And I need to also have this conversation with Somu because this is issue on almost all the tracks, right? See, Karthik,
Yeah.
what you should do is you should not invent the wheel or reinvent the wheel. You should talk to maybe inspection team, right, and get their deck because that is probably in better shape than any other solutions, right? And then use that as a template and do this deck accordingly. If we take that approach, at least basic level of consistency will be there, and then we look at avenues to enrich it further.
Okay.
But this is good work, guys. I mean, I think in terms of so meat is there, we have to just wrap it nicely. If I can make that statement being a vegetarian. All right.
Okay, then let's move on to the application demo. Priyanka, you want to take it over?
Yes, Abhishek. I'm sharing
Yeah.
my screen. Please let me know once it's visible.
Go ahead, it's visible.
So Priyanka, one more thing we have to follow consistently, right? Irrespective of which demo it is, which audience it is, right? So in solution deck, they will talk about personas and journeys. Then when we launch it, right, for demo, we should never launch it, from Dev Studio. We should always launch it from application portal. And before we launch, say that um, for this persona and this journey, we are going to experiment how it looks, so that there is continuity from and proper handover, from deck to demo.
Sure,
Uh,
Bharat. Yeah.
yeah, this is not a criticism. I just a different way of doing it.
Sure.
Okay.
As this is our first sprint, we will be launching the portal from our operator ID, and in the upcoming sprints, we will have a separate portal for each user roles.
Okay. Sure. So that end user portal, right? We should have it configured quickly and always use that, right? Because Dev Studio is not the right medium for giving business demo.
Yeah, sure.
Okay.
So this is our interaction portal, and the user role is care manager. Here, the care intake process would take place. Care intake process can happen through phone calls, messages, or web channels, or through representatives. Now we can see default options as phone call of patient, provider, and outbound phone call. Here, the prior authorization request can be created by all the three of these options. So during this demo, we will proceed with the creation of prior authorization request from a phone call of patient.
Got it.
We have some existing patient details in our system. Using those details, we are going to search the patient search from here. From here, the care manager can select the list of patient from the list. After selecting the patient, we could able to see the patient 360 profile. This is it displays about the patient details and their summary, and what are the care plans they are currently undergoing. As it is a new patient who is not have any cases with our system, we could not able to see any cases over here. So to create a prior authorization request, we will select add action, and we will be selecting the task type as request prior authorization. Here the requested channel would be our phone call, and we have four types of authorization type. As Manohar explained, inpatient, outpatient, and referral, and pharmacy. All these four has the same process, but only difference we could able to see the variation in the service type. When we select of type pharmacy, we can see details about the drug service review and where the place of service would happen. So other than this, when we select inpatient, we could not able to see a type urgency as emergency because the patient would be available in the hospital itself. And for other three authorization type, we could able to see a type of urgency emergency. When we select the emergency type, this prior authorization request is not applicable because he needs to directly reach out to the nearby emergency room. So for this demo, we will proceed with the authorization type inpatient and our urgency as a elective. I have the prior authorization request was having some issues. I have created a new request now. Um, Now the system displays the member details and next is the patient provider details. A provider is the person who is going to provide healthcare service to this patient. We can select the details by searching the NPI ID or tax ID, or by default the system would display the existing records. The next one is the practitioner. A practitioner is a certified person who will going to diagnose or treat the patient. It can be same as a provider, or else we can also search it from the list, or we can search through NPI ID or tax ID. The facility is a place where it is an hospital who is going to provide a service to the patient. So next is related to the authorization service type. Based upon the requirement, the user would be selecting it. So these are the admission details. So how many days he is going to stay in the hospital, and what is his diagnosation information. So now the care manager can review the patient details and the request details. Now the case has been routed to the clinical review. Clinical review, the user is a clinician. From his work basket, he will be selecting the case. So this is adding a guidelines and it is an optional task. So all the necessary documents regarding the guidelines, he would be attaching it.
So Priyanka and team, in this industry, right? At least in US, whatever prescriptions are sent, right? Those are still sent by fax. Even though everyone has gone digital, they are still relying on fax. When I heard about it, for the first time, I was not believing it. But then I realized that that's the ground reality. So the biggest challenge, right, anyone would have is to process these facts quickly and process them without error. So in our demo, is there a moment where we are looking at facts and then proceeding further?
No,
No,
we
Bharat.
have this option of attaching the documents here, Bharat. So this fax problem was there in 2016-17. Like I saw a YouTube video as well. But this
Even now it is
framework is
there, Abhishek. I was working on for this Molina account. So the biggest challenge there was facts not working or people misreading facts or the facts not getting delivered. Even response from Molina was also through facts only.
okay.
Yeah. So we need to especially if we are taking this to Pega world, we need to consider that ground reality for US. And why it is good for us is because we can bring in AI movement around facts. So on the left hand side, we can have a fax that was sent by physician. On the right hand side, we can have a text that is extracted by AI. So there are various OCR tools we can use. I forgot the name. Maybe I will recall that and share in this chart. So we can integrate with that tool, or we can just uh, mimic that tool's behavior. So on the left hand side, facts material showing, and on right hand side, whatever system has extracted. And then there is an opportunity for reviewer to either accept whatever has been extracted by AI or override it. So that is how we can add value and bring in AI moment. Because otherwise,
Well,
see, if we don't do that, then it will be like simple workflow, right? and people will wonder what value we are adding, right? Workflow implementation itself is a large value, big value, but when everyone is talking about AI, we need to always look at AI moments, right? Then the next thing is the recommended plan, right? So there also we can probably bring in AI saying that okay, doctor has given this prescription, but our AI indicates that there is another better prescription available which is cheaper. In reality, this will be a massive AI project, but we can just stub it, right? We don't have to. I mean, it can come from like lookup table in Pega. So if this is a plan, for this plan, what are the better plans available, right? That can come from a local table. When we are giving demo, no one is going to ask us show your AI code, right? So that's another thing we can do to bring in AI movement. And trust me on these 2 points, because similar demo we had done in our past, my past organization also. So it could resonate well with many people. So I'm pretty confident that doing this will not be a problem at all. It will add value.
Sure, Bharat.
Yeah, and again, I mean, I was going on and on. So if any of my long speech you couldn't understand, just ping me offline. I will try to explain you in better terms.
Yeah, Bharat, I'll ping you, Bharat, separately,
Okay.
to understand the requirements.
Once all the necessary documents are attached, this case will further move on to the next stage. Here in this clinical review, the clinical review person would be selecting the status, whether this request is approved or denied. So we have 6 types of options. When it is certified in total, the prior authorization request is approved. When it is not certified, it is denied. And pended and contact payer, it's same. The case will again route back to the clinical review. Until it gets certified, the case would remain in the clinical review work basket. Modified is a partially approved state, and no auth required is the request prior authorization request is not required, and the case ends here itself. So in this demo, we will go ahead with 2 options. One is certified in total and another one not certified. First, we would see about A1 certified. Clinical review comments will be added, and routing to MD is an optional one. So I have selected the checkbox to route this case to medical director review.
Yeah. So here also we can bring in AI movement, so that recommendation that is there, right? Route to MD. It's just a matter of articulation, right? Currently, it appears to be a static field. So for everything, that option is there. So instead of that, we can say that looking at this particular case, AI recommends that it is routed to MD for his review. Okay.
Okay, but sure, yeah.
Does that make sense? I mean, did you get my point? We don't have to do, I mean, change much, technically. Maybe by default, if it is recommended by AI, by default, it can be checked. And then some message pops up saying that system AI has recommended it for MD review. Kindly decide. And then human will have ability to either accept that recommendation or not accept. So maybe from checkbox, the static checkbox, we may have to convert that into a pop-up.
Yeah.
So then we go to the next step, either by accepting that recommendation or continue as it is by rejecting it. Okay, Karthik, I think you got it, right?
Yes, yes.
Okay, good.
Now the case has been routed to medical director review.
So is MD medical director or master of medicine? I mean,
No, it's a
MD.
medical director.
It's
It's medical director only.
Okay. I thought I was thinking MD as in the super specialist.
Doctorate of Medicine.
Okay.
A medical director can also view the request details and he can also change the status. Now the case has been routed to nurse for the review. Here the request details will be displayed in the read-only format. This is the task related to the request notification. Once the user has selected this notified as a checkbox, the system would be creating an admission case for this patient. So this is a confirmation task to make sure all the related tasks are completed. Now we could able to see the admission cases created for this patient, and all the request related details we can find it in the administrative tab. For the resolved approved case, we could able to see actions which is a reopen. Here the provider details, member details, and request and guidelines detail would be displayed here. Next, we would see the process when the medical director has denied the authorization request. I have already processed a case and I have reached out to the medical director review stage. Sorry, it's in a clinical review stage. After clinical review approval, the case is routed back to the medical director review. If the medical director also feels this case needs to be denied, he would be seeing the request details and submitting it. He can also change the status back to certified or pending or modified. Now the case has been routed back to medical review coordinator. This medical review coordinator person would be arranging a call with the provider, and he will be consulting with him whether this request needs to be approved or denied. This task is make sure that all the documentation work is completed. Now this task is related to calling the provider. He will be calling the provider, and the provider accepts the denied process means he needs to click on this checkbox. This is also a similar task which we have seen it in the certified process. Once it is notified, the prior authorization request will be completed. This is our prayer authorization case. We can able to see the status as resolved denied, and we have two actions here. One is peer review and reopen. Peer review, again, we would be sending this request for further medical director review. Reopen is we can still able to change the status of. We can still able to change the case details here. With this, we are concluding the demo for the prayer authorization request.
Any questions?
No question. This is great. I think in very short span of time, we have implemented, very detailed demo. As I said, right, we should now get into the next gear and look at, opportunities of bringing in those AI moments.
Yeah, okay, man.
And then just check, the data. For example, in this to-do list, due date is missing for the third one, right? Usually for any task, due date will be mandatory, right? So if there is any data that is not correct, we should get rid of that. And this Ledena Kehun, right? Is it a default name used by the framework?
No, we have a list of test data available, Bharat.
Okay, this was one of the test data, right?
Right.
See, while it is catchy name, it is difficult to pronounce for many of us, right? So I don't know, maybe it looks like either Vietnamese or Filipino name. I'm not sure, but if you don't pronounce it correctly, and if someone in the audience, right, is from that country, it will leave a bad impression. So we should always use simple personas.
Okay, sure, yeah.
All right. No, thank you so much, guys, for coming up with really nice demo. I appreciate it.
So, Bharat, thanks for your time. So the feedback that you have provided, that is what we are considering as the use case for us in the next sprint.
Okay.
We will incorporate that and we will do a demo with you once again.
No, sounds good, Abhishek sir. And again, see, I am also learning, right? This space. I am by no means, expert. But together, let's learn and create something
Yeah,
new.
absolutely, absolutely. I would respect that. Okay, so the suggestions are well accepted. We will try to incorporate them, and if we have any challenges, we will reach out to you, sir.
All right, sir. All right. And
Okay.
then Shrikant, I mean, see, he had also created a deck which I had liked. So Karthik, I mean, check that deck also, because he had started with research and given good story there.
Yeah, okay.
During hackathon, right? So see if we can leverage that deck also. Some points from that deck.
Srinath Vallipe,
Yeah,
na?
sorry, Srinath, not Srinath.
Okay.
Sure.
All right. Thanks, everyone.
Fine. Sure. Team, can you stay back for a couple of minutes?
I will drop off, Abhishek.
Sure. Thanks, Bharat.